warm welcome. I'm glad you all are part of this panel. Absolute pleasure in hosting this session. All these sessions are part of our COVID Unity series, and we at Voice of Healthcare believe that with these collective efforts, we will win this battle against Corona. Absolutely. But before moving forward, I want us to know each other. So although people know Dr. Aggarwal and Dr. Lal very well here in India, but it is good to know each other and understand each other. So, and Fred is a very good friend of mine. We were together in INSEAD, France, way back in 2016. So let's introduce each other. So I'll ask Dr. Aggarwal to introduce yourself first.
Krishna Kumar Aggarwal, KK Aggarwal people call me. And I am currently the president of Confederation of Medical Association of Asia and Oceania, which has 19 member countries, including Australia and New Zealand. And we also virtually meet every week, and we have been meeting on COVID-19. And I'm also past national president of Indian Medical Association, and currently I'm the president also of Heart Care Foundation of India. With me, I have Professor KK Kalra, who also joins me, and he is the former CEO of NABH, and he is currently the director, Heart Care Foundation of India with me.
Great. Nice to have you, sir, here.
Thank you.
Dr. Lal.
I'm Dr. Arvind Lal. I run a pathology chain of laboratories in India, nearly 204 labs we have, and about 6,000 pickup points and about 2,600 collection centers. And this is the oldest laboratory in India. And this was started by my late father in 1949. And I took over only in 1977 after he had passed away. Before that, I was teaching in Armed Forces Medical College in Pune. And we are at the forefront of COVID-19 testing. We are one of the first private labs in India to have been approved of this testing. And I'm happy to say that now we are doing more and more work. We are now getting geared to handle more patients. And the Government of India strategy is somewhat changed, which we'll discuss during the course of the thing. That now there'll be much more emphasis on testing. So that's all I would like to say. I have been the past chairman of Federation of Indian Chamber of Commerce Healthcare Division. Yeah. Today I'm the mentor of the FICCI committee. I'm the past president of NAT Health, that is Hospital Federation of India, and also of the PhD Chamber of Commerce.
I would come to you, my friend Fred, Professor Frederic. Why don't you introduce yourself?
So I'm a professor of surgery at Geneva University Hospitals. Is a city of about 500,000 people, 500,000 people, and we have the only public hospital, which is public and private. We have been heavily touched by COVID-19. However, we didn't overwhelm the health system, which was one of the real good model of managing with a virus. However, we had to stop part of our surgery, but I will probably explain that later, and how we dealt with the virus. And we are now in the process probably to go to population screening for serology of immunoglobulin, and as well doing a lot of testing for COVID-19 in the hospital.
So Fred, why don't you, let's jump into the session. So why don't you tell us, before we discuss what's happening in India, why don't you tell us about Switzerland? What exactly is happening there? What all measures you guys are taking to fight this deadly virus? What are you doing on ground?
So at the time, we get about 30,000 people in Switzerland that have been tested positive on a population of 8.5 million around. Yeah. It means that we have a high incidence of people in Switzerland having that. Yeah. Then the first measure was confinement. Okay. that was for the population, and we closed everything except shops and grocery shops and hospitals and background things that bakery, almost food and groceries. And that has stuck all of the people at home, at least, except those people. We don't have a strict confinement rule. We just think that the people with the civil thinking will stay at home, and we have a lot of things. We did a lot of reorganization in the health system. We got we got usually intensive care unit of 30 beds for Geneva, and then we increased the capacity to 134, changing recovery room into intensive care units, changing operating room into intensive care unit. And then with that, we changed as well. Half of the building of the hospital became only COVID positive building. And we hosted at the maximum peak around 500 people at the hospital at the same time, for a hospital capacity altogether of 900 beds only for COVID patients. That make us change a little bit the way we were organizing as well as the rest of the activity for the normal people to deal with. And we did a very big effort to work with a private clinic. We have 4 private clinics in Geneva area. We are the only public hospital. And basically they hosted us for the COVID negative patient care in Geneva, but not in the hospital. And when the patients are COVID positive, they go straight to our hospital. So we share the burden of the health system between private and public hospitals in a very nice manner. And actually, the situation has reached a peak, and we're more like decreasing the number of patients in intensive care, and we're more like on the flat curve. We didn't went on the exponential one. So we decreasing measure, and we're stepping down. And we have the politics who tell us to three steps to go out. First, we will open care to person and the shops with distanciation measure, hand washing, and not obligatory to wear a mask, but recommended, especially when you see and you're close to people. And then that will be the first measure that will happen next week. And then 2 weeks later, we will open schools again, from big nursery to 15 years old. And then on a third step, a month later, it's supposed to reopen everything pretty much, like universities and museum and the rest, if everything is doing well. So we pretty much reach the peak and think that we're getting out of it now.
Great.
I want to ask one thing, Naveen.
Sir.
I heard you said that 50% of the people in one incidence got infected. What was that? Can you explain it again? 50% of the building got.
Yeah, Fred.
We just gave the building to be completely dedicated to COVID positive patients. And in that building, we raised to a capacity of 900 beds, and we only use 500. So now we're stepping down because we're seeing that at the maximum of the peak, we were around 500, 550 patients hospitalized. And from that was about 50 to a maximum 65 in the intensive care.
So my question to you, Frederic, is that if you have a COVID-only hospital, and there are 500 patients admitted there, they obviously none of them will be in an isolation single room. They will be in a ward distance with 3 to 6 feet of distance. That means they will be meeting each other, they will be talking to each other, they will be eating together, maintaining a physical distance.
No, basically it's a 2 rooms policy. So there's maximum 2 people in the rooms, and there are large rooms, and they're not allowed to go out of the room during the hospitalization, except with a physio. So they're grounded in the room. They got a 2-meter distance between the bed. However, I think we cannot do much better than that.
So why I am asking this question is, in a resource constraint possibility, can a asymptomatic healthcare worker, I'm talking about asymptomatic healthcare worker confirmed by Dr. Lal to be COVID positive, otherwise asymptomatic, can he be posted as on duty in a COVID positive ward?
Yes.
Treat the patients?
Yes, completely. And they wear a gown and mask and gloves. And they change for every patient. So we need much more nurses and doctors because of that, because it takes a lot of time for each patient to be seen and to change the dressing and to change the clothes between every patient.
Take over, Naveen. Naveen, your voice is, you are asymptomatic.
Yeah. Thank you. So thank you, Fred. Thank you very much for detailed description of Switzerland. So while Dr. Aggarwal, while Switzerland is doing well, they are working very hard, and the curve is flattening there. I'm happy to know about that. And I was, reading some articles that BCG vaccine, all those countries where people are vaccinated with BCG vaccine, they are doing fairer than other people. I know BCG is an immunomodulator, but at the same time, WHO has refused to comment on it. So what do you think? It is just a hype, or is there any truth in it?
Let us go back to a South Korean study where in a psychiatric ward, there was a closed room where all the patients were there. Except for 2, everybody got infected with each other.
Okay.
That means their protective level was 0.
Okay.
In a herd immunity, we do expect that with the R value of 2.8, the herd immunity level for COVID-19 should be 30%.
Okay.
So we expect not more than 30% of the society to get infected.
Got it.
After that, no infection will occur. And that's true for Wuhan, that's true for Italy, that's true for many countries where flattening of the curve is occurring.
Got it.
That means 30% of the society is getting infected. But that will be true if this 30% of the society is getting infected over a period of time, because the neutralizing antibodies will form after 12 days. And when neutralized antibodies starts forming, herd immunity chapter would start. In India now we see, except for Jamatis, where the positivity rate is 30%, 40% was in Diamond Princess ship, 40% got infected.
Got
in
it.
Kerala church, in the South Korean church, again 30% got infected.
Got it.
Unless we have a study in India of non-BCG, Jamatis are 100% non-BCG. Because that community does not believe in vaccination.
Got it.
They don't believe in treatment. So we are 100% sure that all Jamatis are a non-BCG population. So ICMR today has announced that they are looking into BCG and they are trying to find out BCG versus no BCG. If we get a data that in India, clusters of cases are significantly less in number compared to others, that means we don't have super spreaders. If we can demonstrate in India that number of super spreaders are low, the things will change. Or if Dr. Arvind Lal can come back and say that a viral load in India between BCG and non-BCG is different. If he can demonstrate the data, whichever cases he has, he only has to ask one question: are you taken BCG or not? And if he can find out and say out of 100 cases that those who have taken BCGs, their viral load on day 3 or day 4 or day 5 is much lower than that, then immediately Professor Arvind Lal will get a Padma Vibhushan.
Yeah, thank you very much. See, the fact of the matter is that, I would say more than 80% of the Indian population has been vaccinated. This is a legacy historical issue, and there's nothing new to thank us or the present the politicians for it. So now the studies which will come up will be after some time. It is now commented there is something definitely going on in India,
Yeah.
that the number of people who have been infected, or who have died of this disease, let's not go into infection, is nearly 450, as compared to in America with 32,000 deaths. So irrespective of how much has been tested, but you cannot hide deaths in a country.
Absolutely. Absolutely.
So therefore, I'm inclined to believe that the virus in India is behaving slightly differently. And I have read reports that the genetically this virus is 5 or 6 places it is slightly different.
Yeah.
And this all happens on the corona part, on the spike part, where the glycoprotein ACE receptors are there, etc.
Yeah.
So what I'm trying to convey to the audience is that only genetic studies later on, and then the immunological studies, immune status of the, or surveillance studies as we call them, that will tell us, but that is going to be retrospective. So right now, this has got, a very moot point, because right now the people in India, or I would say outside India, are accusing Indians of not having tested adequately. So
Yeah.
the government has now, risen to this kind of a challenge, and even private laboratories like us, which were, hardly tested for the last 15 days. So we have jumped in, and the testing now, which we are doing, is about, nearly 25 to 30% of the total cases, which is not a small number. So right now, the priority in India is to catch a COVID-19 patient, and you have to test and as I said, detect, track, and isolate.
Yeah.
So on these 4 kind of pillars is the policy of the government of India, which I agree with, is standing. India is a huge country. Ideally, you should go and start checking out everybody. It's not possible. So the government of India has not done too badly. When I mentioned to you that about 450 deaths in India, as compared to the number which I was telling you,
32,000.
32,000 in America.
Yeah.
So there is something definitely which we have done right, and we hope so, because India is a huge country. We cannot afford to let it get out of hand, and the crux of the pudding will be out on the 3rd of May, when some more data by that time would have been collected, that how many people are positive. But I still maintain clinically, you cannot hide anybody. You can hide a person who is positive and who's not got himself tested. But if that patient deteriorates, he requires hospitalization, his breathing has been affected, and he is having other kind of symptoms also, he is not going to stay at home. So that number is in our favor currently, but let's not, count our chickens before they are hatched. So that's what I would like to say.
The only thing what Dr. Lal I wanted was that once you're doing so many cases, just have a column and ask them, have you taken BCG or not?
Yeah, that is a good idea. That is a good idea.
You may come back with an advisory maybe a week later or 15 days later, that whether they have taken a BCG or not and what is the percentage. I know a large number of data will be required, but at least some preliminary observations can come. You only have to ask one question: BCG taken, BCG not taken.
Yeah, I think it's a good idea.
Yes,
I mean, we have to start taking some baby steps towards it. So yeah, Dr. Lal, you rightly said, although we are testing less than other countries, like Switzerland is, if we compare Switzerland versus India, we are testing 220 per million population, and Switzerland is testing somewhere around 25,000 per million population. So Fred, what do you think? I mean, what all methods you are adopting in Switzerland? Are you guys only banking on RT-PCR, or you guys are also doing, rapid test, which is antibody testing?
So for the moment, you hear me?
Yeah, I can hear you.
For the moment, we were only doing tests at the beginning of the procedure, just for people having symptoms at the beginning, and then we extended to every people that has to come in the hospital now, and that allow us to discriminate between positive people and negative people, and the triage between hospitals for the different care or the different line of treatment, if it's COVID positive or COVID negative.
Yeah.
For antibody, we are running a study now in Geneva, and we have basically we have two big arms. One is a healthcare provider, and they will be all tested and checked if they got antibody, IgG, IgM, and if they develop symptoms later on. And that's one of the arm. And the second arm, we got a representative population of 5,000 people in Geneva that has been built in the last 15 years, which is called the Bus Santé. And those population represent well the average population from an epidemiologic point of view. And we will use that model of a broader population to test them and to have an idea of what's going on the average population. And as we were discussing, it is probably around 30% of the population that has been infected, and a lot of the people have been infected without symptoms. So that's part of the things, but maybe it's 50, maybe it's 70. We have absolutely no clue because of a lot of people are asymptomatic. Yeah. So now we don't know that, and I think we will try to get the answer. So I think the immunoglobulin testing is very important. We try to do it in a prospective manner. However, it's evolving quick because the number of people infected increases well. So it's very balanced, but we've got a very good model for that.
Got it.
We have a huge interest because I think it can lead to a more specific way of dealing with a general population.
Got it. So I'll come to Dr. Lal once again. Dr. Lal, we are talking about rapid test, antibody testing for quite some time now. Although government has, delayed in providing permission to test to private players, but at the same time, we are facing the same challenge in terms of antibody testing. I understand that antibody testing sensitivity is very, very low. Close to 50 to 70%. But what is your take on this? I mean, should we start doing antibody testing? Or, what I mean to say that when it comes to home testing, shall we start giving, these kits to people who are at their home and they can check it and test it, whether they are positive or negative, so that they don't have to come out of their houses? What is your take on this, Dr. Lal?
So, Dr. Nishchal, first of all, this is not a diagnostic test. This must be clearly understood, the antibody test, whether it is rapid or we take from the vein and we put it in a high throughput ELISA analyzer. So that is a different issue.
Yeah.
So right now we are trying to find out the extent of the disease. That means we are in the diagnostic, testing stage or tracking stage. We are not in the surveillance stage. By and large, the surveillance stage is in those hotspots in India where large number of people with this kind of a positivity, like you heard the Tablighi, Jamaat, etc., they have gone, or maybe in hotspots in, say, Maharashtra area, Bombay area, and maybe also in Delhi. Delhi is, of course, number 2 after Maharashtra.
Yeah.
So that is a second step as far as the strategy is concerned.
Yeah.
It must be, explicitly understood by everybody that in India, the test which is there right now is for detection. And detection means that right from day 0 till day 7, there is no antibody test which will be positive. So you have to be in that, RT-PCR is the only test. Yes, later on, when we go into the surveillance stage, yes, I agreed, like, Dr. Rish is saying that, yes, we will graduate to that stage. But that stage is phase 2 in India. And people are already asking me, I'm sure Dr. Aggarwal has been asked this question also, that why don't you do a rapid test? So this rapid test is right now in the Indian mind. When people are talking about so many things and Indians love to, compare notes and, debate on everything.
Yeah.
So it is very difficult even for doctors to understand the actual efficacy of this test.
True.
which we all, four people sitting here, we all understand.
Yeah.
Dr. Kalra will also agree with me. But we do not want to dilute this effort. Otherwise, this will also go. The actual testing, let us first find out how many, Fred, how many tests have you done? How many positive cases are there in Switzerland, you said? 30?
So we did in Switzerland around 30,000 tests altogether, and 30,000 positive tests on 250,000 positive tests. And for the antibody, we will have around 10,000 people.
So they are one stage ahead of us, so which makes sense. And Fred will understand what I am saying. We have only got 13,500 or nearly 14,000 positivity so far, and only 450 deaths. So we actually want to find out the extent of the acute phase.
Exactly.
What Fred is saying is in convalescence phase. So that must be understood explicitly.
Exactly. It makes a big difference because we had from the almost 250, 300 people tested, so 10% positive around. And from those 10% positive, we had 1,050 deaths. So that's a very low rate compared to France, Italy, UK, and even USA. So I think we're pretty lucky in that sense.
And another thing which I can add from my side is that in India, we are, hovering around 4 to 5% positivity of the cases tested. Whereas countries like, USA, UK, Spain, etc., there the positivity rate is 25%.
25 to
30%. This also should be kept in mind for making the future strategies. So right now we are in the acute phase.
Got it.
It's very interesting because I don't think we have a full coverage with BCG in Switzerland, and that makes a difference.
Got it.
I just want to add one thing to what Dr. Lal has said is very clear is the treatment we have learned from H1N1. And we have learned from all acute conditions, the treatment is as early as possible, probably in the first 48 hours, because the viral load is going to be maximum at that particular moment. The innate immunity, if it does not take over, because the acquired immunity will take 7 to 14 days to develop. During that time, you develop the cytokine storm, and during that time, you have the maximum deaths. Therefore, antibodies are not going to pick up a disease in that 7 days. So if you really want to reduce mortality, then antibody testing has no role, because you need to pick up disease early, either clinically or symptomatically or by RT-PCR, and you need to start treatment early. Early oxygen, early treatment, early ventilation, early prevention of cytokine storm can only be done either on assumption or confirmation by RT-PCR. You have no scope of antibodies there.
Got it. So, Dr. Aggarwal,
I want to add.
Yes.
Dr. Kalra.
Only useful, not for treatment, is only useful for screening.
Screening.
Absolutely. In a large cluster areas where you want to rapid testing to see what is the incidence, especially the asymptomatic one.
Government has
rapid test, maybe some help to screen out, and then confirmation by the real-time PCR.
Government has only allowed it in an only containment zone, actually. So I think that's the reason. So, Dr. Aggarwal, while talking about treatment, we have been hearing news about hydroxychloroquine and azithromycin, and hydroxychloroquine is an anti-malarial drug. But I couldn't find a trial with a decent sample size. I read some articles where sample size was, in one article, sample size was somewhere around 60 and another was 15. So how can we trust on these studies?
Normally, there is nothing like anti-malarial or antibiotic. We are looking molecules which has antiviral effects. So hydroxychloroquine is not given because this is anti-malarial. It is given because it has some antiviral effect. So at this, say for example, azithromycin also has some antiviral activity. Similarly, doxycycline has some antiviral activity. Now, a trial is need to occur because doxycycline plus with hydroxychloroquine Hydroxychloroquine also has anti-HIV effect. So all those medicines which are antiviral need to be tried in a new virus. Forget about it, whether they are classified as antibacterial, antiprotozoal, or antiviral. So any drug with antiviral properties needs to be tried in combinations and find out. And with that only you will be able to, till you find out a specific antiviral for COVID-19. As far as today is concerned, we have azithromycin as an antiviral.
Yeah.
Oseltamivir, we don't know, though it is still in the Indian protocol. Hydroxychloroquine has been used as an anti-HIV. It has anti-HIV. Azithromycin, doxycycline, and HIV, anti-HIV drugs, and the monoclonal antibodies. All those drugs which have an antiviral effect. Now, most of these trials where the drugs are failing, because the diagnosis comes after 72 hours and the period of treatment has to start within 72 hours. Therefore, these trials basically has no value unless you start a trial on clinical basis. When I say a clinical basis is that if a patient has fever with cough and breathlessness, and if I say on his that his lymphocytes are low, instead of normal ESR, I find ESR is high, CRP is high. If I see D-dimer is positive, and if I see that he has pro-BNP is positive, then I presume that this is a case of a unusual viremia, which we say, which earlier we used to say HIV viremia. If a patient used to come with fever and hemogram used to show us that his lymphocytes are low, immediately we used to ask, is there a history of contact? It may not be acute HIV viremia. So at that particular moment, unless we start treatment and demonstrate that these patients have not gone into a serious illness, these trials will have no value because they all are starting treatment after 72 hours.
Got it. And Fred, are you guys using hydroxychloroquine and azithromycin?
So I think, as Dr. Aggarwal was saying, there is no evidence yet. So I think that's a huge problem. I know that the French are doing a prospective trial that we don't have the result yet on 3 antiviral and hydroxychloroquine for acute patients. So I think there is a huge interest, but no evidence. So we are using it in some specific hospitalized severe cases. Just as a matter of why not, if the toxicity is not too high.
Something is better than nothing,
Exactly, but we are very well aware that we don't know exactly what would be the potential effect, and that's probably less than the people in France are saying, and that's maybe a little bit more than nothing. So as long as we don't get into the toxicity, probably 30 to 50% of the patients within the hospital have had it, and but because it's cheap and the profile of using is okay, but the data are being collected and will be analyzed, and at the moment there is no evidence whatsoever that will allow us to say yes, we need to use it, or not, we don't need to use it. That's the same for the antiviral. I think it's a very work in progress. However, I think the number of cases and the number of data coming out is getting out very quick, and I think we will have a lot of information within the next couple of weeks or months. But at the present time, we're using it in selected cases in the hospital. We don't give it outside. There is no prophylaxis evidence for that, and that's in a selected manner. I think we can use it, but without knowing it, as long as we don't have the bad side effects.
Got it.
I just want to add, Naveen, here is that mortality is not 3% or 5%. Mortality is either 0 or 100 for that patient.
Okay.
Either that patient will die or he will survive. So for him, doesn't matter 3%, 4%, or 5%. Therefore, if a patient is dying, he's sick, he has cytokine crisis, where we know mortality is 85, 90%. For that patient, I would try every possible unknown drug or a known drug, provided it is not going to harm. Hydroxychloroquine, no side effect. Azithromycin, no side effect. Doxycycline, no side effect. We have anti-HIV drug, giving it for 5 days, carries no mortality, no side effect. So in that particular situation, statistics and a trial doesn't matter. in that particular situation.
Yeah, that's a pragmatic approach as we have here. Exactly.
So with this, I have another question to you, Dr. Aggarwal, that the dominant reason of hypoxia is not related to, ARDS or pneumonia. ARDS, but it is not related to pneumonia, but it is something that this virus attacks, beta chain of hemoglobin. Although I have read it in some articles, but I couldn't establish the sanctity of these articles. So what do you think? Is it, is it true, or it's still under,
It's
research?
still under investigations, but
Okay.
as far as I am concerned, I always say that if the patient will respond differently,
Mm-hmm.
every patient responds differently.
Mm-hmm.
Some patients you will guide that they are sitting all right, talking to you, but their hypoxemia is very severe.
Mm-hmm.
They behave like high altitude pulmonary edema who needs early oxygenation. And if you don't do SpO2 levels, you miss the diagnosis in such cases. This is one type of a patient.
Okay.
Second type of a patient you will find is he has a thrombotic episodes where he has D-dimer is very high. In those cases, if you don't give them TPA or early heparin, you will lose them. That's the second set of people.
Okay.
Third set of people is who have pro-BMP will be very high, and they will have a myocarditis. These are the people who will require intensive treatment. No specific treatment has come as on today. Fourth type of a people will be who have gone into very fast, very early ARDS, who require prone ventilation. So there are people and there are indications to treat them differently. Now, when it comes to, say, for example, if I find a situation where the viral load is very high, now when viral load is very high, that means that in the immediate immunity of the body is not available.
Okay.
The immunity develops after 7 days. My secondary IgM, IgG neutralizing antibodies will produce after 7 days. So how do I tackle my first 7 days? That is the most important. And for that, my body normally produces innate immunity, which is by way of a reaction. If that reaction gets exaggerated, I'm in a problem. That's an anaphylaxis, that's a cytokine storm. It is something like that when you have a crime, the normal police comes, crime branch takes over after a week. And that crime branch is the specific thing that they come into it. Or you say case handled to send it over to CBI after a week. Because they then start investigating throughout the country. So the innate immunity or the immediate response is the most important. If I can provide my patient an immediate neutralization of the antigen, either by plasma therapy, which is only effective in the first week, either I give them a plasma therapy, I give them blood. Why can't I give them blood? Because when the oxygenation is low, I can give them cord blood. Cord blood has a hemoglobin of 18 or 19. If I give them proper oxygenation by fetal cord blood, by oxygenation, by RBC oxygenation, by neutralizing antibodies from a person who has been treated. I'm talking about that. People are talking about give them in serious cases. I'm talking about prevent them and going into seriousness. Once they go into a seriousness, we are losing them. So if I can, and here what I am saying is, if Dr. Lal can come back with a theory that these are the group who are likely to go into cytokine storm, that help has to come from the pathological lab. They have to give us the parameters. If you don't treat at this particular moment, they are going to go into cytokine crisis. And remember, ARDS and cytokine crisis in our country, where are the hospitals? Where are the experts? Where is prone ventilation available in our country? Where is the ECMO machines? We are losing them. Because what we'll tell is our standard answer will be to the relationships. We can't help it. Even in a normal ARDS, our mortality is 85%. That will be the thing we say, that these are the people even without COVID, if they have ARDS, we can't survive these people. That's the way I look at it.
True. Very well said, Dr. Aggarwal. Dr. Lal, when we talk about this virus, you are testing it in your laboratory. Do you think that this virus is mutating, and which can hinder in further developing the vaccine?
The virus is definitely behaving in not the same way as it has behaved somewhere else.
Yeah.
But again, it is very premature to pinpoint it. I also already mentioned that I have read reports that the Indian virus is somewhat different in 5-6 places,
Yeah.
and that is on the glycoprotein spike protein and with the ACE receptor.
Yeah.
It is somewhat different.
Yeah.
Now, this difference could probably, in the long run, be advantageous to us, that it is less virulent.
Yeah.
It is not less transmissible. It is more prone to, the drugs which you have all mentioned.
Yeah.
And therefore, the outcome of this virus in India could be, or I would say that we pray, we keep our fingers crossed, it is slightly different, and that may help India, because Indian population otherwise, we were absolutely ill prepared to handle such a pandemic, of this kind of quantity. So what I'm saying is that let the time pass. The 3rd May, after the second quarantine, when people would be inside for 40 days, and
Yeah.
40 days is a long time,
Long time. Yeah.
for the curve to flatten out. Or if the curve doesn't flatten out, then you have a real problem. So let us wait and see. But being born optimistic, I would say I'm cautiously optimistic even now.
Got it. So, Dr. Agarwal, do you think that we'll be able to see vaccine in 2020? Where are we? Where are we in terms of vaccine?
See, Naveen, how does it matter? Can we still afford the flu vaccine today? Is it within the reach of a common man? Has a flu vaccine or a pneumonia vaccine till been included in India in a universal program? We are talking about how will US rebuild its economy. When you talk about vaccine, we are talking, unless government of India comes back with a vaccine which is free for everybody at an economical cost. If this US and other people bring vaccine, it will not be less than, say, even pneumonia today is 2,300 rupees. Can a common man afford? So
I think
I still feel vaccine, let it come when it comes. Let it
I
come.
will I will
I am
slightly
not going to be optimistic. Oh my God, 6 months from now, after that, I will be relieved of taking social distancing because a vaccine is coming. When
so
it comes, we will handle it.
I would like to slightly disagree with you here, because for past 2 months, Indian economy is almost zero.
It's shattered.
We are not earning anything. We are not, I mean, government is not earning any taxes. If even with 1 month taxes, we can, provide free vaccines to our country, we are saved. I mean, rest 11 months,
You are talking something. Is the government providing PEPs to the private sector? No.
no,
So
no.
they are only providing it to the government sector. So
Yeah,
when the vaccine comes, they will provide it to 20% of the population, not
yeah,
80%. So
yeah.
let's not,
So,
let's
so
face it when it comes.
Yeah. So you rightly pointed out that government is this PP is a very big problem. Fred, do you think personal protective equipment is a problem in Switzerland also? I mean, I know a lot of medicos, even in India and abroad, they are not, I mean, they are working only with surgical masks.
I
So what do
think
you,
most of the time we're working with surgical mask,
oh my
except
God.
in COVID intensive care. But in the general ward, we just work with normal masks. And I think that's definitely a problem to provide the FFP2 or more mask is a problem all over the world. And the people go in the airport to try to make the flight come in another country. We heard about those stories. So I think capacity to build those masks and to provide it is increasing worldwide.
Yeah.
Um, and that's something very positive. The price is probably getting higher as well. And I think at the moment it is a problem for everyone, every single doctor to get the appropriate mask and protective tools. However, I think it will get better as soon as economy is starting, like in China, and they start to build masks that they send all over the world. So I think it's probably a good going in the right direction. But at the present time, I think not everyone has a capacity to be well protected, even in a very wealthy country like Switzerland. And
So,
vaccine, as Dr. Aggarwal was saying, probably in a very wealthy country, you will have a vaccine for everyone, like we have the flu vaccine, and it's a good example, but it's probably not possible in every country.
okay. So I think we have a very good discussion. We have a hard stop here, but before we take this stop here, I'd like to have, last response from you guys. So, Dr. Lal and Dr. Agarwal, what do you think? I mean, now we are getting almost the same cases every day, slightly lesser. And can we say that curve is flattening now in India?
Yeah. So if I may add here,
Yeah,
the curve is definitely flattening from the time, factor.
yeah,
And the time which we have been able to buy,
yeah,
say till the 3rd of May, has not allowed the peak of the curve to become like a bell-shaped curve. It is
yeah,
more or less slightly, on the touching the x-axis.
yeah.
Having said that, this has also given a country like India so much of time to prepare for themselves.
Got it.
And last week, I'm giving you last week figures that we needed 6.2 million PPEs and N95 masks, they were in short supply. But all this is being made up, 1.2 million masks were received, and 1 million coming from Singapore, and 722,000 coming from Indian suppliers. All should have been supplied. And the ventilators also, I think there are less than 40 or 50 people on the ventilators in India, which is a very nice, situation for India. And they say that 5% of the people, which Fred also was saying, will be put on the ventilator, ultimately. So there are 1,400 ventilators available in India, which is far too small a number. And
Yeah,
here the public and the private sector have already placed, and we've placed that there'll be 40,000 ventilators. And there are Indian, manufacturers out of the blue who have
yeah,
come in, who are manufacturing this, like the Agwa and the BEL, Bharat Electronics, car manufacturers like, Mahindra and Mahindra, Maruti. They're all manufacturing, ventilators
yeah,
along with this Arvind Mill and Lal Bhai
yeah,
Group. So all, then, well, those people are manufacturing the PPEs. I'm sorry, but
yeah,
fact of the matter is that India has got time. I don't know what the real number is going to be in India,
yeah.
but we definitely have bought time for ourselves to get prepared. So, which is, something, deleterious is going to happen in the future.
True.
I think we will, be able to match up to that challenge. That's all I would like to say.
What's your take on?
I just want to add one thing is that there are two types of lockdown. One lockdown is called Modi ji's lockdown. Whenever he wants to finish, whenever he wants to take it out, he's free to take it out.
Yeah,
But as far as my personal lockdown is concerned, that has to be forever, at least for the next 2 years. My personal lockdown means my responsibility to save myself. For me, flattening the curve is for my family,
yeah,
not for the whole country. So if everybody starts behaving, I need to flatten my curve of my family, my relations, my colony, wherever I'm
true.
going, my office. If everybody starts looking at that, things
Yeah,
will change. So for
agree.
me, my health is my first concern. I make sure that in my family, in my office, I protect myself. And that's my personal lockdown. And that's what my stand in this is. I don't want to work on statistics. For me, either I survive or I don't survive.
Got it. Thank you. Fred, what do you think? I mean, what is, from your standpoint, how we as a country doing to fight this disease? What is your perspective?
You
What is,
mean you mean in India?
yeah, in
Yeah,
India,
yeah.
India.
We want to ask Fred. Fred, what do you, after all what you have heard, how
Yeah,
do you think India is doing?
yeah,
I think India has a big chance because you got time to see what happened. As Switzerland had chance over Italy, we had the months more to come and to get prepared. And I think that's probably what is very interesting. And the longest you will come into the critical phase and to the exponential increase, the more you will be prepared and the less deaths and less you will lose people. So I think it's going in the right way. I don't know the general health system in India. It could be very good for some people and very bad for others. And I think the poor people will probably suffer a lot from that, like in America, like in Peru, I think, and in different other countries where the poor, the health system for the poor is not so good. So people will die. But you got time to get ready. And I think that's something very positive that I hear today.
Okay, thank you. Thank you very much, Dr. Arvind Lal sir, Dr. K.K. Aggarwal, Dr. Kalra, my friend Fred. And with that, we come to the end of the session. I think one of the fantastic sessions I ever had. So on behalf of Voice of Healthcare and the audience, I would like to thank our panelists. Thank you very much. Thank you everyone for watching us. I'll see you in the next session. Till then, stay safe, stay in. Thank you very much. Corona namaste. Thank you very much.
Bye-bye.
Bye-bye.
Thank you.
Thank you.